All right, hi. Good evening, everybody. This is our PA Health Talk on this Monday evening here. And the topic of the Health Talk today is going to be hip and knee replacement surgery. Um, I'm John Mercuri. I am a joint replacement surgeon, also referred to as adult reconstruction specialist practicing at our Geisinger musculoskeletal facility at the Marketplace at Steamtown in Scranton. And I do my surgeries at the Geisinger Community Medical Center. I'm the director of our fellowship and associate director of our residency, and also an associate professor at the medical school with Geisinger Commonwealth. Just some relevant disclosures. I do some consulting work for Medacta, which is a company that makes some joint replacement implants. And so that's relevant to the talk today. I also want to disclose that I'm a big supporter of technology and using technology in joint replacement surgeries. And I can explain as we kind of go through this talk a little bit why I think that's important and the value that you can get out of that. Thankfully, Geisinger as an organization is also heavily invested in the use of these technologies. So starting off, first topic is going to be the knee. So what is knee osteoarthritis? It's a disease of the knee joint where there's a loss of cartilage that happens over the course of living your life. The reason I'm starting with the knee is because it's about 3 times as common as the hip. And the process involves a lot of inflammation or swelling of the joint. Particularly knee osteoarthritis is the kind of arthritis that people associate with the wear and tear of getting older, kind of your joint wearing out. There are many other kinds of arthritis, and some of them can be replaced with joint replacement surgery. And I sort of have a list of them there, but they are, by the numbers, somewhat less common of options than just having knee osteoarthritis. So the risks for knee osteoarthritis, there's some things that you can't change. We just know from looking at science research studies that knee osteoarthritis is more common in women than in men. It's more common in older patients than in younger patients because there is some element of sort of wear and tear over life. Seems to be a role for genetics in knee osteoarthritis at least. And in theory, maybe there's some things that you can change. You could potentially develop post-traumatic arthritis or other types of osteoarthritis from trauma in your younger years. Generally maintaining a strong muscle environment around the knee can help the longevity of the knee joint. There is a relationship between how much body weight you're carrying and how much stress you're putting on your joints. And certainly people that are very overweight can sometimes unfortunately start to develop arthritis a little bit younger in life than what you would otherwise see, maybe if they were a little bit lighter. So those are at least some of the big things where there is the ability to kind of change that and maybe change your trajectory for the arthritis. The symptoms are actually probably very well known to patients. It's going to be primarily you're having pain in your knee that's limiting your activities. And this is being a big problem for you doing the things that you want to do in your life. Pain at night or even when you're resting does become particularly common, especially as your arthritis gets more severe. And as you could imagine, if you're having really bad pain in your knee at night and you're waking up every couple of hours, that is a major problem for your kind of day-to-day life, because then you start getting not only emotionally exhausted with your knee pain, but are physically tired and exhausted because you're having trouble sleeping. Very common that you can get fluid building up inside the knee joint when you have arthritis in the knee. Also common that you can get swelling of all of the tissues around the knee. And this is maybe something that's even more noticeable to a person than just the fluid in the knee. But a lot of times they kind of come in and look just like that photo that I put there and say, hey, doc, like what, my knee is so swollen, and so there's an associated swelling that happens around the knee joint. The joint can get stiff. You can start to lose your normal motion of the joint. In particular, it can be very hard to maybe get it fully straight. And that's a little challenging because you feel like you're kind of walking around on a slightly bent knee all the time, and that's not very comfortable. And same thing, a lot of times people start to get stuck in an ability where they just can't bend their knee past a certain point, and it kind of gets stuck there, and so it can get stiffer. And then sometimes there are these mechanical problems that start to happen with the knee. People might say, oh, my knee is giving out on me. or I feel it getting locked or getting kind of stuck in a position, or it's unstable. Those are some things that people can feel when they have knee osteoarthritis. As far as tests and what tests do you need, really, you only need an X-ray of your knee when you're standing up. That's it. You don't have to get fancy. You really don't need CT scans. You don't need MRIs. They really don't provide much useful information for the overwhelming majority of people that have knee arthritis. You may have an orthopedic surgeon choose to order those tests for you for some reason if they're looking for something in particular. But really, it's just the X-ray of the knee standing up, and the things that you see on that X-ray are sort of on. There's been a couple knee X-rays as we've gone along here, but at least on this one with the notes on there. On the side of the knee where you see that big space between the bones, that's your thigh bone and your shin bone, and that space in there is where the cartilage lives. The cartilage is the cushioning inside your knee joint. But the cartilage that you have, by the time you're sort of 16, 18 range for, a woman or a man, that's pretty much what you're getting. It doesn't grow back as it wears away. And we have not figured out a way to make it regrow, at least in any helpful way for knee arthritis. So that space there shows where the cartilage is. So you can see on the other side, there's no space. That's where the phrase that you hear people say, well, I have bone-on-bone arthritis. It means that all the cartilage is worn out to the point that the bones are physically in contact with each other. It's bone touching bone. And then your body will respond to that by creating little sort of bone spurs and depositing some more calcium there. And these are all just very common findings that you can see on an X-ray when people have bad arthritis in their knee. So you always want to start by not doing a surgery. That's the number one goal. So the question is, what are the non-surgery treatments that you can do when you start to get knee arthritis? Well, there's oral anti-inflammatory medications that you can take that are not prescription related. I think these are really common for people, know what they are. There's going to be Advil, Aleve, Motrin, things like that. There's prescription versions of those same category of medications, prescription anti-inflammatories, things like Mobic or Celebrex or diclofenac or Voltaren is what that's sometimes called. It's always a good idea to touch base with your regular primary care doctor to find out if it's okay for you to be taking those medicines or what amount of them you could be safe taking. There are occasionally scenarios where people can be very safe taking these medicines on a very regular basis over long periods of time. And then there's other scenarios where it's really best to maybe not even take them at all or use them sparingly. So that's something that you do kind of have to parse out with your doctor. There's topical anti-inflammatory, and this generally seems to be much sort of generically safer that pretty much anybody could reasonably use it. They used to require a prescription, not any longer. You can now get Voltaren topical gel or topical cream just over the counter in the pharmacy. It has diclofenac in it as its sort of drug chemical, and that can work well for people. Physical therapy is still extremely helpful for knee osteoarthritis. The knee, I like to describe it as sort of a use it or lose it kind of a joint. And so you want to, the more that you keep it going and keep it moving, the better it behaves itself. So physical therapy and strengthening the muscles around that knee joint and keeping its range of motion active is actually really helpful to make it feel better and manage the arthritis. Kind of as I mentioned earlier, sort of weight loss. People have kind of suggested some different numbers and ranges on this, that potentially if you lose, a pound of body weight, your knee thinks that maybe you lost even 3 or 4 pounds because it's a sort of a multiplied effect on the knee joint. So even what seems like kind of small amounts of weight loss, even just 10 pounds, could have a noticeable effect on making your knee feel better. Modifying your activities. This is kind of the category that nobody wants to do, right? That's the reason that you're seeking treatment, is because you don't want to be modifying your activities. You want to still keep doing all the things that you want to do. Soft knee braces, they again can seem to be very helpful for some people, not helpful for others. There's certainly no harm in trying them. They're relatively, not that costly to get them, and for the people where it helps, it's helpful. And then ice or heat. I like to just approach this as whatever works for you. I have patients that come in sometimes and swear that the heating pad makes their knee feel better, and I say, okay, great. And then I have other people that say, oh no, if I take a bag of frozen peas out of the freezer and put it on my knee, that makes it feel better. That's fine too. Whatever works for you. There's really not a rule on that. Sort of the next step of non-surgery treatments is the whole category of injections. This is injecting medicine like that photograph there into the knee joint to try to break the cycle of the osteoarthritis process. Now, again, as I said, we don't really know any way to grow the cartilage back. We can't really reverse the process, but we can stop the pain with these injections. And sometimes they're remarkably effective. I've been in practice here now 6.5 years since I came back to the area, and I have patients that for 6.5 years have consistently be coming to see me to get injections in their knee, and that has been enough to do it for them. And that's a great option when it works that way. It doesn't necessarily work that way for everybody, but again, there's not a lot of harm in trying it. The categories of injections, steroids are kind of the most common. These are not the steroids where you like build up muscle to hit home runs. These are corticosteroids. They help with pain. There's a few different kinds that you can use. That photograph there, that white syringe is a corticosteroid. Platelet-rich plasma is sort of a newer category of things that's been happening in recent years where they can actually draw your blood and extract the platelet and plasma aspects of your own blood and inject it back into your knee, and it has a really surprisingly effective anti-inflammatory effect for managing osteoarthritis. It works really well. There's been some work that they've been doing of maybe using some other anti-inflammatory compounds in injections. There's some Geisinger related options that are available here in northeastern central Pennsylvania that I actually don't think are maybe that readily available really anywhere else in the state. One of them is APOS. It's sort of a shoe therapy where our physical therapist can evaluate you and give you a pair of shoes to wear at the end of the day that kind of takes the pressure off the knee and takes the pain of the arthritis away. We actually have, we've had nurses who work in our operating rooms who have tried this and have put these shoes on at the end of the day and just have said, wow, that's really surprising how well that works. That's an interesting option for people to try. We have iovera nerve ablation. Basically what that is the pain nerves around your knee. We can use sort of an ice-based, the freezing type of treatment to kind of zap those nerves and stop the pain signal coming from the knee because you freeze the nerves. And the last thing is called a knee KG, sort of like an EKG for your heart. It's a knee KG. It's basically they can do a gait. Our physical therapist can do a gait analysis of watching you walk on a treadmill. And there's a lot of information you can actually suck out of that gait analysis to figure out, what is wrong about the way this person's walking. Are they putting too much pressure here? How they're limping, and then change things about, the physical therapy that you might do, or the thinking about changing your pattern of walking to help make your knee feel better and kind of get out of that rut that you're sort of in. So those things are all really interesting and are available here as things to try. There are lots of other treatments that people try, but there is no convincing evidence that any of them actually work. My personal approach on it is that if it's not really costing you money out of your pocket and it's not harmful to you, it's certainly fine to try all these things. Because I have patients that come to me and absolutely swear that acupuncture makes their knee arthritis better. That's fantastic. You should do acupuncture. You should make your knee arthritis better with acupuncture. I just would not really necessarily be able to show you some sort of a research study that says, hey, this is a thing that's working. But if it works for you, it works for you. I'm totally in favor of that. I think the most common thing that people ask me about is there are injections you can put into a knee that are, people kind of call them by different names. Well, maybe there's a gel shot or a lubricating shot, or sometimes people call them rooster injections because there was one variation of this that was manufactured and had something to do with items from the comb of a rooster that was put into this shot. There's many different versions of them made by many different pharmaceutical companies. Again, it's not that they do not work, they do, but they've never shown to work any better than steroids, for example, or PRP. All these injections seem to kind of work equally. So one thing we run into is occasionally it can be a problem with your insurance company getting a pre-authorization for a gel injection, or there might be a higher out-of-pocket cost for a gel injection. Don't feel obligated to have to try that because all the injections seem to work relatively similar. And then, unfortunately, there are people where you try this whole gamut of all these things I talked about in these past 2 slides and try to get control over the knee arthritis, and it just doesn't work out. At that point, we move to knee replacement surgery, which actually is more so a resurfacing of your knee. We don't actually really cut your knee out, sort of shave the damaged arthritis areas off and then replace those shaved areas with metal caps that go on the end of each bone to kind of like capping a tooth almost. And then a piece of plastic will go in between those pieces of metal, and that plastic's like your new cartilage. And you could resurface or replace the entire knee, which is what those x-rays are showing there. Or you could do just a portion of your knee where the arthritis damage is, and that's sort of the cartoon drawing where it shows that darker gray is the joint replacement on just that one section of the knee, but the remainder of the knee, that's that white shiny appearance, is your own knee that's left behind. Generally, about 15% of patients that have arthritis in their knee would be appropriate to get a partial knee replacement. But about 85% of people kind of have more damage around the knee where it would probably be a better idea to do a full knee replacement. Then getting back to kind of what I started with at the very beginning, I'm a big supporter of technology. I do not basically do any surgeries in my practice that do not have some element of technology to them. I don't really do manual surgery, and because I think I can get, better results by using the technology. And Geisinger is very well resourced in this area. So at least for knee surgery, things that we have available are either standalone or in combination of multiple of them together. We can get patient-specific instruments made for you based on CT scans of your legs and 3D models of your bones. We have different types of computer navigation systems to use during the operating room to help guide our instruments. We have robotic assistants that can help in the operating room where a physical robot can help position the instruments or the implants in certain locations that's kind of hard to eyeball with just your own eye. The newer area where there's a lot of ongoing research across the country and development are these sort of mixed reality or augmented reality options where the surgeon wears a pair of glasses and it shows them the information that they need from the CT scans and everything while they do the surgery. Geisinger, at least, is sort of notable because it was the first healthcare system in northeastern or central Pennsylvania to introduce Stryker Mako robotic surgery to do joint replacements. And it currently is the only location in the state of Pennsylvania where you can have access to the Medacta NextStar augmented reality technology, which is one of these systems that I've mentioned to perform these joint replacements. And that's just a testament to Geisinger's investment in sort of these technologies and where we can take them. And then why is technology important? Well, if you look at this slide, look at all these people. They all look different. Well, to give them all a joint replacement that's really the best thing for them, you kind of have to get a little patient specific to place the joint replacement. And so everybody's knee is going to have a unique shape. There's going to be unique ligaments, unique motions to the knee. One of the fastest growing areas in knee replacement right now in the United States and really internationally is this idea of what's called kinematic alignment, which is really just another way of kind of describing the knee surgery should be performed in a way to align your leg and your knee with the patient-specific knee that you have. And every single person is going to have a slightly different version of that, kind of like how everybody's fingerprint is different. The reason to do this is you will end up having a faster early recovery. It will be less painful. You're going to have less swelling and less bruising. You can get more range of motion. And then in a more delayed sense, you'll end up with what people describe as a more natural feeling knee to them. The early recovery seems to be in the first 2 months is really where your biggest benefit is going to be, but the more natural feeling knee is a long-standing benefit where it doesn't feel as much of a prosthetic. And these are just 2 photographs and a video of a patient that I did this past year, and she let me share this. This was actually day 12, I think it was, after I did her knee replacement. It was slightly less than 2 weeks where she came for the visit to take her dressing off, and she's got some bruising and some swelling because she had a knee surgery, but she's moving her knee almost like a normal range of motion and wearing flip-flops and walking up and down the hall. This is actually a realistic thing that you can accomplish for people today when you do these kind of knee replacement surgeries. I happened to see another patient of mine recently, actually out eating dinner at a restaurant with her husband, and I had this was a Saturday, and I'd only done her surgery on a Tuesday. So, and she kind of, I was walking by and she said, "Oh, hey," and kind of pulled me to the side, like, "How are you?" But so it is possible to accomplish that now, and some of these things I've just talked about are what are enabling that to happen. So we're done with the knee. We're going to move on to the hip. Similar concepts. Hip osteoarthritis is going to be a disease in your hip joint where you start to lose the cartilage. It's less common than knee arthritis, but it's more common than the shoulder. So knee and hip are still the sort of most common arthritic joints that happen where we have to do surgeries to replace them. Again, lots of inflammation and swelling involved with that process. And same as before, there's other types of arthritis that can impact the hip joint. That's not just osteoarthritis. Kind of similar concepts to what we just talked about for the hip. Things you can't change. Also said to be more common in women, more common as you get older. There's an association between getting hip arthritis later in life and having congenital dysplasia, which is basically a slightly abnormal shaped hip joint. And it was not anything that your pediatrician might have noticed at the time that you were born as a baby, and it never caused you any problems over the course of your life until many, many years down the road, it starts to catch up with you. And occasionally the starting to catch up with you can sometimes even happen. It's usually in women and even in their late 20s. I have had to do hip replacements on women where congenital problems have caught up to them. But I have also met women in their 60s where I look at their x-ray and say, "Oh, hey, you know what? You lived 60 years with a kind of congenital hip defect that you didn't even know about, and now it's become a problem." So can't really change that stuff in any realistic way. Things that you can change, again, similar, trying to avoid traumas that can damage the joint, keeping strong muscles, losing weight. Particularly, there are scenarios where the bone inside the hip joint can die, and as it loses its blood supply and it dies. And probably the two most common reasons that we seem to run into that is a heavy amount of alcohol drinking can tend to cause that to happen for people, and a heavy use of using steroids, not the kinds of the injection ones that I mentioned before, but the kinds where maybe people have had to take a lot of oral steroids to manage medical problems, or they've had to use a lot of oral or inhaled steroids to deal with asthma or lung problems. Those steroids can sometimes cause the bone to die in those areas. The symptoms, again, is going to be pain that will limit your activities, pain that's going to be at night, that'll wake you up at night, getting hard to put on your shoes and socks. You can't reach down far enough to actually get to your shoe and sock. Sometimes patients come to see me and they're, wearing flip-flops even though it's wintertime because they can't reach down to tie a shoe. The pain from hip arthritis is almost always felt by somebody in that blue area. It's in the groin or the crotch area of the body, and sometimes it starts to spread down the leg, the front of your leg towards your knee. That's the area where hip arthritis hurts. There are other areas around the hip joint where you can feel pain. You can feel pain in your buttock, and a lot of people describe their buttock as their hip. Pain in the buttock region is probably more related to a sciatica, and it is probably not going to be related to a hip arthritis. Similarly, and that would be the yellow area there. The red area is similar. Pain on the side where you feel that hip bone out by your pocket. Again, a lot of people, call it their hip bone. Like, "Oh, that's my hip." Pain out on that side is usually going to be some type of a bursitis or maybe a muscle tear or a tendonitis on the side of the joint. If you're not really having sort of the groin crotch pain and the pain on the front of the leg, it's probably not going to be related to your hip joint. There's always, strange examples otherwise, but that's the overwhelming majority of people. Again, what tests are you going to need? Same thing that we mentioned before. You want to get an x-ray of your hip while you're standing up. The reason for the knee and the hip to have you standing is because you're putting your weight on the joint. When you lay down, things kind of relax and look a little different, and maybe bone-on-bone arthritis in a knee, for example, might not look like it's bone-on-bone when you're laying down, but when you're standing, then they're touching. So same thing again, CTs and MRIs are not particularly needed and helpful unless there's some really unusual circumstances, and you'll have the same process where your hip is a ball and socket. Sorry, that photo ended up being a little bit blurry, but your hip is a ball and socket, and there should be a space between the ball and socket where the cartilage lives. And if your space is all gone and the ball and socket are touching each other, that's the bone-on-bone arthritis of the hip. And what happens in the hip actually is it kind of starts to wear away almost like a pencil eraser, and your leg slowly shrinks a little bit as arthritis in the hip gets worse and worse. And sometimes people start to notice, hey, I feel like my right leg that's hurting me, I feel like it's like not as long as the left leg. And that's actually true because it's kind of wearing itself down. That's something that we try to fix when we do the surgeries. So again, what are non-surgery treatments? You want to try to avoid surgery if you can help it. Similar stuff to what we talked about before. There's going to be non-prescription oral anti-inflammatories. There's going to be prescription oral anti-inflammatories, trying to lose weight, trying to modify your activities to the degree that that's reasonable. One thing that's very helpful is using a cane, but in your other hand. And that's sort of the drawing that I have there. And not to get too overly complicated with it, but basically if you stand on one leg and that leg is the leg that you have arthritis, your body's going to fire all of its muscles and try to keep you standing on that leg. And when it does all of that, it's really going to hurt your arthritis. If you have a cane in your other hand, you can use your other hand and arm and that cane to do all that work to kind of keep you upright on that one leg and let everything relax around the hip, and the hip's not going to hurt as much. So that will work much better than having the cane in the same side. And then you can get steroid injections put into a hip joint, the corticosteroid injections. They will be done with ultrasound because, as you can imagine, it's kind of hard to guide a needle all the way down through your skin, down into the inside of your hip joint without having some sense of where you're going. So we do that pretty frequently with our sports medicine colleagues who help us with the ultrasound. And again, you can certainly find lots of other treatments that people will try and things that certainly will work for people. And if something works for somebody, you should do it. But again, I don't have a lot of convincing evidence to sort of prove that anything is working. And then for surgery treatments, it's in a sense a little bit more simplistic than the knee. You've got a total hip replacement where you replace the entire ball and socket of the hip joint, and that's what that X-ray is there. There are still these scenarios where you could perform a procedure called a hip resurfacing, where you kind of put a little cap on the end of the hip bone, maybe more similar to a knee replacement in a sense, but that has become very rare. It's done for only certain patients, and it's so rare, and there's so few surgeons that do it frequently enough to be good at it, that if you really wished to have a hip resurfacing and you were an appropriate patient for it, you'd have to get referred to a particular specialist who did it. And at least for myself as a surgeon, I'm actually not one of those people who would do hip resurfacing, but it's very uncommon in 2025. Another comment to make is current day, it does not matter where the incision is placed around your hip to have your hip replacement performed. There was a lot of science research done and conversation about this starting probably upwards of 20 to 25 years ago, where people were advocating that, you know, if you do your incision in a certain location on the front of the joint, it can be a big improvement for a person. As it has turned out, any sort of modern research comparison that's been done on it has showed that they're basically equivalent, maybe slight differences one way versus another for either or, but no convincing sort of winner. So it's really just become your surgeon is going to have a way that they do their hip replacement, and that's the way they do it, and that's the way they're going to be good at doing it, and so you're going to end up getting a good outcome from that. But which of those two it happens to be really doesn't seem to matter much anymore. And then similar technology options to what we talked about. I think the only thing that's not really on that list is sort of the patient-specific manufactured instruments. That's really not a common thing with hip replacement, but there are various types of computer navigation, again, various types of robotics. Geisinger's robotic platform that we have is the Stryker Mako system, and then similar augmented reality systems. And again, Geisinger being the only place where that's accessible, at least right now. as that's a relatively new technology. And as I mentioned a few times now, Geisinger is very interested in being on the forefront of these things, which makes it fun being a surgeon here because then you can have access to all this stuff. And again, similarly, why is the technology important? Well, we're back to this slide. Look at all these different people. They all look different. They're all unique. The thing that's really particularly unique for a hip replacement is everybody's spine and their pelvis move together in a very unique way. It's actually a funny coincidence. I actually literally gave this lecture to our residents and fellows this morning. So I'm completing the bookend of my day by talking about the same topic again. But your pelvis and your spine, they're connected and they move together in a certain way, and everybody's moves in a sort of unique way. If you don't position your hip replacement in quite the right way for that person's unique spine and pelvis motion, you can unfortunately get this scenario where you have the middle drawing there where the ball and the socket pop out from one another. We don't like that. We don't want that to happen. So we plan in such a way to put the pieces in that they don't happen that way. But doing that planning and using CT scans to plan that, using the technology to execute it is very helpful to eliminate that potential complication. Then as far as, who should do my surgery, it is going to be important for you to have your surgery done by a surgeon who specializes in doing joint replacement surgeries. There's been multiple research studies done on this topic. These are just a couple that were sort of recent ones. The one from 2020 came from New York City, from NYU, and actually one of the surgeons is at the Hospital for Special Surgery now. And then that other study is from Rush University in Chicago. These are very prominent research organizations in the United States that publish a lot of our sort of guiding research on these topics. And if you can have a specialist do your joint replacement, you'll have a shorter surgery time, lower complications, less use of pain medicine, and a higher patient satisfaction. And as it turns out, Geisinger has the largest department of joint replacement specialists in northeastern and central Pennsylvania, and it is growing. We're going to have at least 2 new members joining us this upcoming year. And we have just as large of a department of joint replacement specialists as any big academic medical centers that people might feel like they want to travel to. Our 4 that we have in the Northeast right now are the 4 of us here. I'm John Mercuri, but we also have David Colasar, Jim Murphy, and Doug Vanderbrook. I'm up in Scranton. The other guys are more sort of Wilkes-Barre based in their practices. And then as far as making an appointment, Geisinger actually has a lot of easy ways to make an appointment. There's a variety of different phone numbers you can call. You can go to their website. You can click schedule an appointment. You can find a doctor. You can look up any of us and the names I just mentioned and look up our websites and click book an appointment. It's pretty easy to get an appointment scheduled. And so that's all I've got there talking about knee and hip arthritis. So I guess at this point, we'll see if anybody either here or on the internet has any questions.
I have a couple of questions that came through. The first one, or a group of them, are talking about losing weight and being able to get knee replacement surgery. And if I'm stating it correctly, it seems like so you're immobile because your knees hurt. They send you to physical therapy. It feels like the knees hurt after physical therapy, and so it's discouraging. But yet you're still asked to lose weight. So, is there any insight to what's the deal?
I think what they're getting at is sort of the following scenario. Joint replacement surgery sounds very happy and rosy, however, being one of the joint replacement specialists that does these surgeries, unfortunately, Geisinger is sort of the referral center to deal with all sorts of complications that can happen from joint replacements, and unfortunately, sometimes maybe even with our own patients. The rate of complications of joint replacement go up with certain aspects of the patient that might not be optimized. So if you, for example, have diabetes, but that diabetes is not controlled well, it's much more likely that you could have an infection or you could have a problem healing your wound. If somebody, one of these topics, getting back to the question, is if you have a body weight that is very heavy, you have a much higher risk of all sorts of complications happening from your joint replacement. And again, the one that I fear the most is infection. You get an infection in a joint replacement, it is a very challenging, difficult process that takes many months and multiple surgeries to try to fix. And so we want to do everything we can to avoid the risk of there being an infection. And so sometimes I think I probably wouldn't phrase it maybe the way that those questions were. I would never recommend sending a patient to physical therapy to try to lose weight. That's not going to be effective or helpful. Instead, what I recommend, if we do have a patient come to my office and they're above, Geisinger has defined for our patient population, specifically in this area, what is sort of the threshold where the weight is going to become a problem. If I have somebody come to my office and they're over that weight, I actually recommend that they go to the Geisinger Weight Management Clinic. We have a very robust system here of nurses and nutritionists and nurse practitioners and physician assistants and surgeons and non-surgeons that run our weight management program. And they are going to be your help, like they're your lifeline. They will figure out how to get your weight down. And it could be any combination of things that they might do with the nutritionist. There's a variety of new medicines that have come out in recent years that can help patients lose weight. There's surgeries that have been around for a while to help patients lose weight. And they will work with you as your partner to get your weight down, not by telling you to go walk on a treadmill of physical therapy to lose pounds. They're going to help you as doctors to lose weight, to get you down to a safe level, to then come back to us where we can then perform your surgery and not have to worry about those increased risk of complications.
That was my mistake in terms of interpreting all the banter going back and forth. So the actual physical therapy piece is my knees hurt, go to physical therapy, and my knees hurt after physical therapy. And I lumped it together with the weight loss piece. So
Sure. Well, we can talk about that too. It is, I think that those other things I was mentioning, like the oral anti-inflammatories, particularly the injections, you need to do something first to break the cycle of pain to let you do the therapy. It is usually not successful to just grit your teeth and muscle through therapy and come out the other side of it. Although I have seen some people that have done that, and I guess hats off to them. but I would suggest instead we do something to manage your pain, to break that cycle of the inflammation and pain, and then move forward with physical therapy. Physical therapy really is a conversation of knees. Physical therapy, from my opinion and the opinion of a lot of other joint replacement specialists, is not really indicated for hip arthritis. There's really no effective way to relieve pain for hip arthritis to get you to be able to do therapy to help you out and make you better. And then even on the back side of it, after hip replacement surgery, physical therapy really does not offer much in terms of a benefit to recovery from your hip replacement. And so I have never, in my practice being here, ever sent a patient for physical therapy after hip replacement because it's just not necessary. So really the physical therapy conversation is in the realm of the knee.
I have a few more questions.
Go.
Do you have any questions? I don't, no?
No.
Okay, so why is it that you have to sometimes wait for a knee replacement in terms of like you have knee pain, you might be in your 40s or 50s and they're saying you can't have a knee replacement now because you're gonna have to get another one. So we didn't touch on that.
No, well, that's I feel like that opinion seems to be generationally related in orthopedics. I don't really know if that's a relevant conversation that joint replacement specialists are having with people. Like what I would discuss with people is you have a problem in your joint, in your hip or your knee, or maybe that example I used of the younger women that have the congenital problem and maybe they're only 28. I mean, sure, we can do some things and we can do some injections, but it's almost like in particular for somebody who's younger and comes to me and they're only 40 something and they have bone on bone arthritis in their knee. They're not going to live the rest of their life without getting a knee replacement. They're too young. So I do not encourage patients to say, oh, you should kind of martyr yourself and just deal with the pain and the damage that has to your activities or your quality of life or the kind of job that you may be working, because the younger patients are usually working and not retired. Our joint replacement technologies, I feel very comfortable saying could have a 30-year lifespan to these implants. And so what I would mention to somebody is, sure, it might be possible 30 years down the road that maybe there's some type of a tune-up type of a surgery that might have to happen to your joint replacement. Most commonly, it would seem to be that maybe the plastic would have started to wear by that point. But to say, oh no, you have to just live in pain for 15 years before you get your joint replacement so that you can then eliminate the possibility of ever having some additional surgery in the future, I think that's a very unrealistic thing to tell people. So that's not at least what I would advise to a patient. But it was, and maybe rightfully so, more commonly advocated for in the past because our technologies are getting better. All the stuff I just talked about, but also the implant technologies are getting better. And so the longevity of these implants now is much longer than what it was, 25 years ago, let's say.
So you were talking before about, they said rooster comb injections to prevent knee replacement. So what they're asking about the process for getting into knee replacement surgery. So if you find the modality to kind of help manage the pain and you keep doing it, you said you talked about having someone who keeps coming in for shots and that's great and all that kind of stuff. But is there a time limit where you're like, enough with the shots, get a replacement? Or
so yeah, again, I think this is another one of these has changed over time. It seems like it was more common that was thought, oh, maybe you should only have like 3 shots and then shots are up. Now it's time for surgery. That doesn't really seem to be relevant, at least for myself and my own patients. I will give you shots for as long as they're working. And if we're 6 and 7 years down the road, and we'll just keep doing that. The reason to not use that as a treatment anymore is it no longer works or maybe never did work that well. Yeah, there's not I think the encouragement to somebody to say, hey, maybe you should think about surgery would be, well, we've given you, 4 of these shots now over the course of a year, and every time you get one, it helps you for a month, and then you just have pain for another 2 months. At a certain point, maybe just have a conversation like, is this actually really working? Because the people that I mentioned where it's been 6 or 7 years, I mean, they're getting very good relief for the whole period of time between each injection. Having incomplete relief in those intervals is, not the point. The point is to try to make your joint stop hurting.
and again, the rooster comb or the chicken comb type of thing, that is not a replacement for a knee replacement.
Yeah.
That is,
It's a good point to bring that up, actually. I think that the rationale when those types of injections were invented was literally, this may lubricate the inside of your knee. As it turns out, they really don't do that. They cause a same anti-inflammatory reaction inside the knee to stop the pain as the PRP injections or the steroid injections. Everything is basically causing an anti-inflammatory response in the knee. It's not really a lubrication or putting some sort of like a spacer in between the bones. That's not how they work.
and then a question about osteoarthritis in terms of replacement for the bad knee. Is it always osteoarthritis in terms of bone on bone that grinds it down, or are there other things that it's going to end up to be osteoarthritis? Like they're like, I have bad knees. I've always had bad knees.
Yeah.
Since I was in high school, I've had bad knees. I don't know what that means.
It's a little hard to tell, I guess, in that particular scenario what might be going on, but sure, there are things that can happen to people over the course of their life. Well, I was in high school and I tore my ACL and I got it fixed, and that was way back when, and now we're 30 years down the road. And this knee that I had that ACL repaired on has always kind of been my bad knee. I've always had like a little bit of a trick with it. But now it's like, it's really hurting. It's really hurting. It's really hurting. And you get x-rays of both of their knees, and the knee that never had that injury looks totally fine. And the knee that had the ACL repaired is very bad arthritis. So that kind of stuff can happen over, long periods of time as, injuries or meniscus injuries or stuff like that evolves. Or somebody maybe dislocated their kneecap when they were younger, and that caused some damage to the underside of the kneecap, and then many years later has turned into arthritis.
Is there anything that we need to worry about? Sorry if I keep asking you the questions. Do you, no, okay, so you guys don't have any questions?
Kind of like changing the subject though.
Okay.
Go ahead.
Yeah.
They cough.
Mhm.
That's something they take. We've been taking it for the last 4 years.
The pill version?
Well,
Okay.
and we have, well, you know, we have that pretty much, I think it's that. It seems like that helps. Is it okay to keep doing that?
Yeah, so I think the best person to answer that question is your primary care doctor, because the risks of taking it the long term are, could it damage something in your gastrointestinal system? Could it cause some issue with your kidneys? But if you've been 4 years in and, your blood work looks okay and your doctor is comfortable with it, then you can kind of keep on doing that. That would be fine. That's not going to be a universal answer for everybody.
So the question was around the impact of neuropathy and trying to get a knee replacement. And my understanding is they suffer from neuropathy where they can't feel their feet.
Yeah.
Does that disqualify them if they have, I mean, I guess it's an odd question because they can't feel their feet, they have neuropathy in their legs, but they feel knee pain. So,
Yes. Well, I mean, for myself, no, I have done knee replacements on people with neuropathy in their feet. There can be many different reasons for neuropathy. I think the things you want to watch out for is if the reason for the neuropathy is you have diabetes that's not controlled well, that would be a problem. If the neuropathy was a problem where sometimes people start getting wounds on their feet because they don't have the sensation on their feet, you can't really do joint replacement surgery, a hip or a knee, if you have an open wound or regular kind of open wounds. But just the neuropathy itself should not be a problem. In fact, I just in recent weeks had to do a sort of complex knee replacement surgery on a person where their neuropathy had gotten so bad that it did involve their knee. And because they weren't feeling any pain in their knee started to really kind of fall apart and go off into left field. And we have particular kinds of implants and things we can do to even replace a knee like that and not have to worry so much about the fact that they can't feel it. So no, I think that's something, again, seeing somebody that would be a specialist in joint replacement is like a reasonable thing to have a conversation about. But I wouldn't use that as any sort of a immediate, cross you off the list type of thing. Yeah.
and they said that so it's now public health information, but they don't have diabetes. They just have neuropathy. So they have a numbness in the bottom of their feet and their knees hurt. So the question was, am I a candidate? I'm like, oh,
Sure.
yeah.
Yeah. I mean, maybe we've touched on sort of a general concept here, though, that orthopedic surgeons, even joint replacement specialists, I mean, a lot of what we do is very technical because we are performing these, surgeries for people. And sometimes people kind of comment, it's almost like, bone carpentry. It's actually much more complicated and nuanced than that. I ask people 18 different questions when they're in the office to find out all these things. What's going on with your diabetes? What's going on with any, have you had any cancers in the past? Have you ever had blood clots? Have you, when was the last time you saw a dentist? Do you have any issues with neuropathy? Like, you have to fold all this together to create an entire picture of somebody. We're not just looking at x-rays and saying, oh, bones are touching, surgery time. It's more sophisticated than that.
That's helpful. I don't have any questions that are different from what we've already kind of discussed.
Sure. Anything else? Anybody else? How do we do on the time? Oh, not so bad. Okay. But yeah, I would encourage you all. Here, I'll go back. Anybody in person or online? These are the four of us that we have in the Northeast right now. Please, reach out, make appointments. We'll be happy to talk to you in person, examine your knees, look at your x-rays, talk about all these things. I think it's great when people come with their family members, come with their husband, come with their wife, come with their granddaughter, whatever. I think it just helps have a better conversation about the whole thing. And This is our team for right now, and as I said, we're growing. There's going to be at least 2 new people joining us in the Northeast this upcoming year. So we've got a pretty robust department of people to help with joint problems.
So, what's the difference between the Medacta technology and the Mako technology?
Yeah, so there are some very extremely detailed differences between these things that for somebody who's maybe a nerd about joint replacement, I can spend a lot of time thinking about that stuff. But I think the way to think of it from the perspective of maybe a patient is using, I guess my opinion, this is why it was my disclosure, my bias is I think technology helps. And I think all of us do, because all of us are using technology in our surgeries. The flavor of technology you use is kind of more like, do you have an iPhone or do you have a Google phone or a Samsung? But it's not, do you not have a cell phone at all? So there are some small differences between robotics or navigation or augmented reality. There's some small differences between using a CT scan versus an MRI to plan something, using the 2 orthopedic companies that Geisinger has partnered with, and they have been incredible partners for us to really improve the quality of the implants and care that we can give here. Are Stryker and Medacta, the 2 companies you just mentioned. Doesn't matter, whose software package you happen to use. That's not really that important to spend a lot of time trying to figure out. I think it's more just, are you using it or are you not? Because you're going to do a much better job giving somebody a patient-specific result for their hip or knee replacement and avoid potential complications from that if you're using technology to help you do that.
That's another comment. So you talked about the slide where everybody's different and that why technology, because technology helps you. But they're asking, I guess, specifically, what does technology do? Is technology's not replacing the physician?
Oh, yes, it is.
Yeah.
No, the surgeon has to be there. We have to be performing the surgeries. Mostly, I guess the way to think about it would be the amount of bone that you may have to shave away to remove the damaged areas. The way you do that, sort of how much to take or what angle to position it, or those sorts of concepts. That's what the technology helps you do, because it can guide your instruments to get you in that location. And then even in the actual insertion of the implants themselves, how do you rotate it in one way or another? How do you tilt it in one way or another? The technology can physically aid you in putting it into the right location. And these things like a 0.5 millimeters worth of additional bone, or a 0.5 degree this way, or rotating a thing so many degrees this way. This is very difficult to do with just your eye. That's really where the technology comes in to help, and all of the planning. I think almost more than just performing the surgery. For me, being able to use all this stuff to plan out your patient-specific surgery. I like to describe it that your surgery is done digitally before, often weeks before, you ever actually show up to the operating room. I already know what sizes are going to be in there. I know what angles are going to be. I know how much bone's going to be taken off. I know if maybe there's going to be something tricky I got to look out for. It's all pre-planned ahead of time. And I mean, that's an extremely powerful asset to go into a surgery and basically already have digitally and mentally performed that surgery. Then all you're doing is just, making it happen.
So I'm a fan of Dr. Pimple Popper. This is Dr. Pimple Popper's on dermatology, has nothing to do with orthopedics. But one of the things that she's always talking about is she doesn't know what's beneath. And so she's like, it would be very helpful sometimes to be able to kind of scan in and see what's happening, because you don't know what's there, and you can easily slip and slide and create more problems. So she's always very judicious or very cautious in terms of how deep she'll move and what she'll take out of the patient. Sorry.
Right. Yeah. Well,
That makes sense.
yeah, this is kind of doing
That from the final.
Oh, there might be a lot of people that watch.
Yeah.
Wow. So anyway, I guess, thank you. I appreciate the time to come talk to you guys. Hope you have a good rest of your Monday night. Stay warm. And, come see us in the office. We're here.